Thank you very much. I would like to thank Professor Yakopoulos for inviting me here to deliver this talk. So, what is the problem? Here is the INDT trial. We see that irbesartan is superior to amlodipine placebo, but some of the patients receiving irbesartan will eventually progress in CKD5, and we don't know when the effect of irbesartan will take place. A clinical case. A 65-year-old lady with CKD3, A2, diabetes mellitus, arterial hypertension, coronary artery disease, has cholecystitis. Due to a recent acute myocardial infarction, he can't, cholecystectomy cannot be performed, and he gets a cholecystostomy. He develops a severe AKI, and she is under renal replacement therapy for 4 months. After 4 months, she has stage 4 A2 chronic kidney disease, and the question for us is the patient able to undergo a cholecystectomy? For us, the relative question is what is the peri- and post-operative prognosis concerning her renal function? So, in clinical practice, we use blood pressure, serum creatinine, urinary protein, and sometimes renal biopsy. So about renal biopsy, we base our clinical decision in a very small amount of kidney mass. And this is very difficult because kidney diseases affect kidney global. I have a global affection for the kidney, but there is sometimes sampling errors. So these are very relevant questions when we think about biomarkers. And biomarkers, or biomarker, is any substance, structure, or process that can be measured in the body or its products and influences or predicts the incidence of outcome or disease. So, about chronic kidney disease, chronic kidney disease is the presence of renal structural disease with renal function deterioration, independent of etiology, with a duration for more than 3 months. And it is, in the developing world, it is the 10th leading cause reducing life expectancy. So, prognosis involves also acute kidney injury and the transition to chronic kidney disease through acute kidney disease. And we know nowadays that stage 3 AKI is associated with increased incidence and prevalence for end-stage kidney disease and death. The other concerning event is that the 20-year-old patient suffering from chronic kidney disease stage 5 has about the same mortality with an 80-year-old patient who doesn't have chronic kidney disease. So it's catastrophic for our patients. So what are the CKD progression mechanisms? Everything begins with the kidney. We have the tubular cell, we have the endothelia, we have fibroblasts, we have immune cells in the kidney or outside the kidney. And we have, this is a paradigm, it doesn't describe the whole process. We have NFKB activators, we have endothelial mesenchymal transition activators, which affect tubular endothelial cells. They activate fibroblasts and matrix deposition occurs. There are also NFKB inhibitors, endothelial mesenchymal transition inhibitors. When the tubular cell is affected, growth factors and chemokines are produced. These can recruit immune cells. And in turn, these immune cells interact with the other players in this game. So biomarkers are produced within the kidney. They are expressed in the urine. We can see them in kidney biopsies. And also these biomarkers can be produced in extrarenal sites. So these are the new biomarkers. So I do not expect to read all this. It's impossible. And there's an evolving field. So the new biomarkers can be used in combination, can be isolated, and there should be a differential approach concerning CKD etiology and therapeutic approach. And we should remember that we should have an individualized interpretation. So I will give you 3 examples concerning proteomic analysis, protein analysis, and radiological analysis concerning biomarker diagnosis. The first one has been reported by Dr. Roumeliotis. I would like to stay on this slide and say that the patients having increased CKD273 peptides in the urine are those patients that will rapidly progress into CKD stage 5, and this marker outperforms proteinuria in the early stages of chronic kidney disease. This is very relevant for us because at this point we can address therapeutic approaches. The other marker that I would like to show you is tubular DICOF3. This is a protein which is produced in the tubular cell, and when the tubular cell is damaged, it's released. Its release attracts T cells, which activate fibroblasts. DKK3 can activate fibroblasts separately. And this leads to fibrosis. So we have 2 experimental models. We have an adenine diet model. When you feed mice with diet, they develop fibrosis. And when you have mice which are DKK3 knockouts, they do not develop fibrosis. In the other model, in A, when you ligate the ureters, the mice develop fibrosis. But when you give antibodies neutralizing DKK3, you don't have any fibrosis. Taking this concept one step further, we have this study, which involved an observation for about 2,035 patient years from a cohort involving patients with various CKD stages, involving patients from stop IgA nephropathy study, both in the enrollment and treatment phase, and biopsy patients. What this study showed is that increasing DKK3 in the urine predicts renal CKD progression. And this happens particularly in patients not presenting with albuminuria. Furthermore, when you test this in IgA nephropathy patients, you see the same effect in the enrolling phase, but you can see during the treatment phase, some patients who had increasing values of DKK3 in the urine also progressed into chronic kidney disease. And this can show us which treatment is appropriate for our patients. Furthermore, concerning treatment individualization, you can see we have 3 distinct cases of, the first one is C3G glomerulonephritis, microscopic polyangiitis, and granulomatosis with polyangiitis. And you can see that this marker, after different treatments, is reduced before the reduction of proteinuria and before the fall of creatinine. Furthermore, taking into account patients receiving or prepared for thoracotomy, you can see that we had urines for all of these patients, and you can see that there are 3 groups. Group A had no significant change in renal function. Group B progressed not so bad, but Group C had a very worsened progression. And DKK3 could stratify these patients. These patients, before having this thoracotomy surgery, had an increased DKK3 in the urine. So it can classify. So nowadays, there are also radiological approaches, and the thematic is a little bit complex, but when the tissue oxygen in the kidney is low, we are having an increased R2 value. And with this method, this bulk oxygenation method, we can address renal tissue oxygenation. And we can see that patients having a reduced oxygenation in the kidney, irrespective from proteinuria, they have a higher progression rate for chronic kidney disease. The other thing is renal interstitial fibrosis, and we all know that when the kidney has a great extent of kidney fibrosis, the prognosis is ominous. But some patients who have more than 80% fibrosis on the biopsy do not progress to end-stage renal disease during a 10-year follow-up. And over-reliance on fibrosis on biopsy may therefore erroneously identify patients as having advanced CKD at a time when interventions may still be effective. So the other thing is how to detect fibrosis. So we all know what Brownian motion is. This is the random motion of molecules due to water content. And there is renal diffusion imaging, which can identify fibrosis in the kidney based on this motion. And what one can take out from these studies is that one can see the degree of tissue fibrosis in the kidney, predict renal function evolution, follow macrostructure changes occurring under treatment, and reduce the number of renal biopsies for diagnosis and follow-up. So one has to take account about the cost. Serum creatinine costs about €4, ELISA 30 euros, proteomics 300 euros, and MRI about 250 euros per patient per sample. And because chronic kidney disease evolves over time, these are many samples that or examination one has to perform in order to be accurate, and cost this has its cost. So the new biomarkers are under development. There is always an individualized application. We talked about cost. Equipment and materials availability is very important. For example, the patient who I refer to lives in Crete. In Germany, we could perform TKK analysis in 1 or 2 days. In Crete, we don't have the ELISA, so we remain with a question what is going to happen. And we should never forget that clinical examination and history are also important for our diagnosis. So new biomarkers are the good, chronic kidney disease is the bad, and prognosis is ugly. Thank you.